Today, I will speak about the treatment options for refractory and recurrent macular hole. So, which difference between refractory and recurrent macular? Refractory macular hole are unsuccessfully previously treated macular hole, are up to 10%, and the risk factors are large size, long duration, trauma, uveitis, and presence of drusen, and also high myopia. Whereas recurrent macular holes, that means reopened after initial closure, are about between 3 to 9%. The risk factor are high myopia again, cataract surgery after macular hole repair, and posterior cystoid macular edema. So, but how are we primarily closing macular hole? With conventional surgery, the closure rate is above 90% if the macular hole is 400 micron or less, and the axial length is less than 26 millimeters. Whereas inverted island flap is preferred in large macular holes more than 400 microns, and myopic macular holes with axial length more than 26 millimeters. Two recent meta-analyses confirmed that inverted island flap is more effective than conventional island peeling in terms of primary macular closure in idiopathic large macular hole, myopic macular hole, and macular hole associated with the retinal detachment. But what do we mean for large macular holes? According to the International Vitreomacular Traction Study Group, the classification for macular hole is defined large when the minimal hole diameter is more than 400 microns. But according to the Manchester Large Macular Hole Study, the suggested cutoff to define large macular hole is 650 microns, because the closure rate of these big macular holes was significantly lower in the quartile between 650 and 1400 microns. According to the Beavers macular hole outcome groups, the suggested cutoff to define large macular hole is 500 microns. So, because the probability, according to this study, of a primary macular closure decreased significantly in macular hole larger than 500 microns. So, nowadays, the 500 microns seems to be the cutoff for defined large macular holes. So why does the island inverted flap works? Because the cover flap acts as a plug, isolating the retinal tissue, reducing the shear fluid retinal stress, and because also the ILM works as a scaffold inducing proliferation and migration of Muller cells. Moreover, activated Muller cells express neurotrophic factor and FGF that modulated the gliosis inducing the macular hole closure. The point is why do we only do inverted flaps on large macular holes and not at all macular holes? Because according to the literature, the ILM inverted flap has been associated with the poor anatomical outcomes, because the ellipsoid zone and the external limiting membrane is not completely closed when we do inverted ILM flap. This is better explained in a paper published by Rossi on a scientific report recently, where he was comparing a cover versus fill technique inverted flap, and he found that the cover group improved significantly better than filling group in terms of best corrective visual acuity, in terms of the fixation stability and retinal sensitivity. So the cover one works better than the filling one in terms of the functional recovery, but in large holes, the fill technique works better in terms of anatomical outcomes, because with the fill techniques we have more gliosis. This is an example of a patient with bilateral full-thickness macular hole. At the baseline, the best corrective visual acuity in both eyes was around 0.3. In one eye, the right eye, he had done the inverted field island flap, and the best corrective visual acuity at the end was 0.5, whereas in the fellow eye, he did no inverted flap, and the sides of the baseline full thickness macular were almost the same in both eyes, but in the right eye, the one where we didn't do the ILM inverted flap, just the peeling and gas, the recovery, the functional recovery was much better with the best corrective visual acuity of 20/20. So this is an inverted flap, Visco-assisted cover technique. And we are using, in this case, a technique assisted by the viscoelastic. So this is a patient that was already operated, and he developed a full for a retinal detachment. Indeed, he developed later on a full thickness macular hole. As you can see now, we are doing the flaps all around, and we want to do the cover technique. And in this case, we have we are using the viscoelastic that we are injecting in the middle, and then we are folding the edges of the flap on the bubble of OVD. We are doing all this maneuver with the infusion off, because when we are injecting OVD, we don't want that OVD can move around. So we are injecting right on the fovea, as you can see here. And then we are folding the edges of the hole. So we don't want to have a displacement of the edges. And you can see by the end of the video that the edges are on the surface of the bubble and stay adherent to the bubble. As you know, with the cover technique, you can have a displacement. In this case, the adhesion will be quite strong, and the edges of the flap will be there, that we are not moving. As you can see here, now we have the edges folded on the bubble, and then we are turning the infusion on at 20 millimeters of mercury, not more, not at 40 as we usually do, in order to avoid turbulence. And then we are going for fluid air exchange. You can see that still there, and then we are injecting gas. Two weeks post-op, you can see that the macular hole was completely closed and with a good recovery. So this is a cartoon of the technique. So the BSS infusion was closed, and the cohesive 1.5 million Dalton OVD was injected on the top of full thickness macular hole, and then the 4-petal LLM flaps were folded on the OVD filled full thickness macular hole. At the end, we used 20% SF6. But in case of a failure of primary macular hole surgery, we need to do something different. We cannot do ILM inverted flap because it's not feasible anymore, because the macular hole is already peeled by ILM. So let's go back to the mechanism using macular hole. So we wanna, the rationale is that we wanna eliminate the residual tangential traction, we wanna increase the retina extensibility, we wanna modulate the gliosis, and we wanna also plug the macro hole and getting a scaffold for Muller cells migration. All of these surgical options results in a further stimulate the Muller cells induced gliosis. But let's go for the first one. So when only residual vitrectomy and gas is enough. According to the Manchester Revisional Macular Hole study, the closure was present in 89% of the cases if the reinjection of gas is done within 3 months of the first surgery, and if after the first vitrectomy we found a decrease in minimum linear diameter and increase in macular hole index. What about tamponade of silicone oil or heavy silicone oil? Few cases reported an anatomical success rate comparable to gas tamponade. There's only one prospective randomized study comparing heavy silicone oil with C2F6, and they found that the heavy silicone oil was working significantly better with higher closure rate, but this is the only paper. We can do something different in refractory recurrent macro hole, like application of subretinal fluid. Subretinal fluid application leads to release of abnormal adhesion between neuroretina and retinal pigment epithelium, promoting the position of the retractive elastic macular hole edges. Has been published on Graves 2020, the Apostel study, a survey-based study, 12 vitreoretinal surgeons performing 41 large refractory macular hole, and the surgical technique is an application of perfluorooctane over the macular hole, injection of 3 subretinal blebs, and in order to stretch the retina. And then the perfluorocarbon liquid was removal and subretinal fluid detachment expansion towards the center, including the macular hole, and then a centripetal massage and aspiration through the macular hole. At the end, fluid air exchange, gas tamponade, and face down position for 2-3 days. And in these cases, the anatomical closure rate was about 85% in large refractory macular holes, with the functional improvement in all cases of the macular closure. Regarding the growth factor and neuroprotection, we need to think about the autologous platelet-rich plasma. We know that the platelet-rich plasma is a regulator of Muller cells proliferation and response, can activate the myofibroblastic differentiation, can induce inhibition of the apoptosis and promotion of the survival of the retinal neurons and the photoreceptors. The preparation goes through the 2 centrifugations, so at different RPM, and then we will get the platelet-rich plasma on the above of the line, the white line of the leukocytes. After removal of residual ILM, 2-3 drops of PRP are injected over the macular hole. Has been published by Marta Figueroa, very good anatomical and functional results. In only one eye showed a fibrin-like tissue. We need to keep in mind that we want to have a gliosis for macular closure, but we don't like to have fibrosis. And we know that there are cytokine pro-fibrotic that can induce a Muller glial mesenchymal transition, so GMT. and has been already published in the literature for hepatic fibrosis that the PRP is a promising agent for alleviation of fibrosis. So using PRP, we will also have less fibrosis that we don't like to have, because otherwise we can have a good anatomical outcomes, but not a good functional outcome. And then we can also do autologous or heterologous tissue transplant. So what are the advantages of transplanting tissue? We want to get with this transplant a restoration of outer retinal stratification. So we can do this transplant with the lens capsular flap, ILM free flap, retina flap, or human amniotic membrane. The aim is to have a scaffold for horizontal gliosis and proliferation of glial cells, but also to have a plug, and the aim is to fill the macular hole with a flat flap to decrease the shear fluid retina stress. Regarding the lens anterior capsular flap transplant, the anatomical outcomes are very high, but the functional improvement is not so good. Regarding the ILM free flap transplant, so the transplanted ILM flap is feasible inside of the macular hole and is a good restoration of ES-OS and also an improvement of best corrective visual acuity, so with the closure rate about 90%. But let's have a look at this technique that we are using now for the free flap, because the technique is not so easy. So this is a patient that we were watching for a while that had an adhesion vitreomacular traction, but best corrective visual acuity was still high. And then he developed full thickness macular hole, was operated with ILM peeling, tamponated with the 20% SF6, and then the macular hole stays open, so we had the refractory full thickness macular hole. So our technique was a free ILM flap, Visco-assisted. So you can see here that we are using the technique as we were doing before. I was showing just a few slides before, but in this case it's a free flap. Is not a cover folding technique on the OVD, but is a free flap. So that means we are injecting OVD on the macular hole, and then we are getting the ILM with the forceps, and we are laying then the ILM on the OVD. So the surgical steps are, so we still need valve trocars. We need to stain the ILM. With the infusion off, we inject OVD. We take the ILM with forceps and then lay the ILM on the OVD. And you can see that the ILM flap stays attached on the OVD. We are using a cohesive 1.5 million Daltons OVD. And as you can see, the flap is not moving around. What are the advantage of OVD technique? That is, we are not using perfluorocarbon liquid. Perfluorocarbon liquid require a bimanual technique with the chandelier light, and perfluorocarbon liquid must be removed because of toxicity induced and the risk of dislocation of the flap. With this technique, we are not using chandelier, we are not using perfluorocarbon liquid, just injecting the OVD, and then with everything with the infusion off, then we open the infusion and we do fluid exchange at 20 millimeters of mercury instead of 40 in order to avoid, again, turbulence. And then we are injecting SF6 gas mix at 20%. We are doing now fluid air exchange, and as you can see, by the end, the island flap was still there, and you can see here that it's present, still present. So in the last part, you can see that the day after was already closed, and the flap is after a week was still there. So the adhesion between the free flap and the retina was present, and the flap was in place. This is the cartoon of our visco-assisted free align flap technique. So the cohesive 1.5 million Dalton OVD is injected on the full thickness macro hole, and then we do the peeling and with the infusion off, and then the flap, as you can see, was stuck on the OVD, and then the vitreous cavity was filled with the 20% SF6 gas. So the last option is the human amniotic membrane plug and the retinal free flap. So what are the advantages of this technique? The always available tissue. And also the tissue is a little bit thicker, so the easier handling and greater stability in the macro hole. What about the neurosensory retinal transplantation? So the speculation is the cross-linking between host and graft cells. So an alternative and ectopic synaptic connection of rod bipolar cells. So because of the plasticity of the rod bipolar cells and horizontal cells. The proposed indications are for primary large macular holes, refractory and persistent macular holes, myopic macular holes associated with the retinal detachment, traumatic, and also exudative and associated with the recalcitrant macular holes. And the results was in partial outer retinal band restoration, sometimes with also improvement in visual acuity. The autologous retinal transplantation was published in a retrospective multicenter study of 130 eyes, ophthalmology 2020, and 76 eyes out of 130 were for refractory large macular holes, and the 88% had the macular hole closure rate. With the alignment of neurosensory layers, and also has been reported and visual acuity significantly improvements. So the complications were subretinal and vitreous hemorrhage in 6%, graft dislocation 4%, endophthalmitis 1%, and also retinal detachment. This is our technique, endodiathermy first, and the retinal free flap more than 0.5 diameter, larger than the macular hole. And then we do the maneuver under PFCL or BSS, and we are then getting the retinal transplant from healthy retina, and then we are placing the retinal graft. We are not dragging, but we are lifting up and we are placing on the macula. So we are not dragging under PFCL, otherwise we use further damage of photoreceptors. And then we are going for fluid air exchange. We need to keep in mind that the manipulation and placing of the transplant have to preserve the natural orientation of retinal layers. Otherwise, has been published that if the position is upside down, you will develop edema, and that will remain disconnected from the edges of the previous macular hole. Any proof of viability of the retinal graft itself. So this is still an issue. We can have some, structural OCT that say there is an integration, but sometimes we cannot really understand if there is a flap or if just a dislocation of the retina. Regarding the fluorescein angiography, the vascular perfusion within the retinal graft sometimes is present, but can also lead to a retinal neovascularization. Regarding the microperimetry, the microperimetry improve the fixation stability, but sometimes we are not sure if it's the host photoreceptor or are the photoreceptor of the transplant. And finally, OCT angiography increase the vascular density around the retinal graft, but we are not sure if there is also a vascular remodeling. Last one is the human amniotic membrane. And we know that the human amniotic membrane has a monolayer of epithelium that is rich of growth factor, NGF, FGF, TGF, and HGF, that are very important for modulating the gliosine and stimulating retinal growth eventually. And there is a thick basement membrane and avascular sticky stroma with mesenchymal cells. And has been proposed for refractory macular holes, retinal breaks, recurrent high myopic macular hole, advanced AMD, macular detachment in optic pit, and also macular associated with the retinal detachment. The results are encouraging, and the first point is that there is no post-op inflammation. So this is our technique. So is a bimanual surgery. So we are putting the chandelier first. We are enlarging the peeling, and then we are inducing the perifoveal detachment, with passive fluid needle. Then we are harvesting with the punch the human amniotic membrane. Then we are placing, as you can see, the human amniotic membrane under the retina, and then we are doing fluid air exchange. And as you can see by the hand, is located under the edges of the macular hole. In our cases, we had good anatomical results, but we are not sure about the retinal regeneration. We have a good retinal stratification and gliosis, but we also found a residual foveal thinning in long time with no further external limiting membrane recovery, and we also found an enlargement of capillary free zone. Regarding the issue that are still in technique of human amniotic membrane are about the tamponing that we need to use, and if we can use dehydrated or cryopreserved human amniotic membrane. So far, it seems that there is no significant difference between them regarding the anatomical and functional outcomes. The human amniotic membrane plug is also effective for parafoveal atrophy in high myopic eyes and in recurrent high myopic eyes with the axial lens more than 30 millimeters. We used also as a plug in a patient with retinal detachment associated with the macular hole. This is a case of a patient with 2 previous surgery for retinal detachment associated with the macular hole in his right eye. So the aim is to plug the big macular hole. So we did the fluid head exchange first to evaluate the retina elasticity. Then we did the ILM peeling. And as you can see here, then we did again fluid head exchange, and then we placed the human amniotic membrane as a plug. We were not thinking about the epithelial side or the stroma side because we only wanted a plug. We were not looking about the regeneration, restoration, but we want to close the plug, and we injected oil, and as you can see, the day after there was a nice plug here. The retina was completely attached, and so at the end we got a retina stable on the RPE. So all these surgical options result in increase in retina extensibility and stimulate the Muller cells gliosis. Thank you very much.